from a feeling to the reality. Now, let us first define what is infertility. Infertility is defined as a failure to conceive within 1 or more years of regular unprotected coitus. It can be primary infertility or it can be secondary infertility. The term primary infertility is applied to the couple who has never achieved a pregnancy. The term secondary infertility implies that at least one previous conception has taken place, but subsequently there is a failure to conceive within 1 or more years of unprotected regular coitus. Now, what are the factors responsible for fertility? The factors responsible for fertility are: healthy spermatozoa should be deposited high in the vagina. These spermatozoa remain healthy and penetrate into the uterine cavity, from there into the fallopian tubes. The ovum finds its way into the fallopian tube and where it is fertilized by the spermatozoa. This fertilized ovum then migrates back into the uterus where it is implanted. The endometrium must be in a state of endometrium must be in a state suitable for the nidation and subsequent development. What is fecundability? 20 to 25% of the couples will conceive in one cycle. 50% should conceive after 3 to 4 months and 95% should conceive after 1 year. Infertility facts. Origin of the problem lies 30% with the female, 30% the male factor is responsible for infertility, and 30% both the partners are responsible. 10% remains unexplained. We call it as unexplained infertility if there is no obvious cause of infertility after we have done all the standard investigations. Female infertility etiologies. The cervix and the cervical mucus constitutes 20% of the causes of female infertility. The uterus and the endometrium constitutes 10% of the causes of infertility. Pelvic and peritoneal factors constitute 5 to 10% of the causes of infertility. Tubal factors constitute 30 to 50% of the causes of infertility, and ovarian factors constitute 25% of the causes. This is a diagrammatic representation of the causes of female infertility. 25% of the chunk is due to ovulatory disorders, 15% is because of pelvic endometriosis, 12% is because of tubal adhesions, another 11% is because of tubal blockages, 11% because of other tubal and uterine abnormalities, and 7% is because of hyperprolactinemia. Others, age of the woman is a very important factor. Fertility decreases after the age of 30 years. It is seen even if severely low sperm count is present, the female prior to the age of 30 years may compensate by her fertility. Maximum fecundity is around 25 years. Now, how does age affect a woman's ability to have children? Age of women is a very important factor in deciding the modality of infertility and the treatment. At birth, the primitive germ cells, they provide 1 to 2 million oocytes in the ovaries. Now, this count reduces to approximately 3 lakhs at puberty. This number is reduced through cell death. With increasing age, the quality and quantity of oocytes decreases. Aging oocytes lead to a fall in the pregnancy rate. There is a rise in miscarriage rate. There is a risk of chromosomal problems like Down syndrome, then obstetrical complications like CIH and diabetes. It is seen fertility in a woman declines after 30 years of age. It further declines after 35 years of age, and it grossly declines after 40 years of age. There is a decrease in oocyte quantity. There is enhanced follicular atresia and increased rate of endometrial chromosomal abnormalities. A question arises, is infertility on rise? The answer is yes, it is. Why? Because of late marriage, delayed childbearing, rise in live-in relationship, stressful lifestyle, environmental toxins, radiation, obesity, high junk food intake. Now, this is the major culprit. We enjoy eating the ice creams and the pizzas and the burgers and the chocolates, but then we pay a heavy price for that. Smoking, alcohol, drug addiction, all of them lead to a rise in infertility. Now, when we are evaluating an infertile couple, both the partners should be seen and evaluated and treated simultaneously. Couple evaluation has positive psychological benefits. We should keep one thing in mind is do not blame any single partner. Do not blame anyone. The protocol will vary from country to country, institution to institution, and based on the history and clinical examination, the next diagnostic evaluation should be done systematically so that we come to a definitive diagnosis of infertility, and also it should be cost effective. The end point should be shifted from conception to live birth. The American College of Obstetricians and Gynecologists and the American Society for Reproductive Medicine make the following recommendations. An infertility evaluation may be offered to any patient who by definition has infertility or is at high risk of infertility. Women who are older than 35 years should be evaluated and undergo treatment 6 months after they fail to conceive or earlier. Women older than 40 years require immediate evaluation and treatment. If a woman has a condition known to cause infertility, then also she requires immediate evaluation. While evaluating, comprehensive medical history is obtained from both the partners. History relevant to the potential etiologies of infertility. Targeted physical examination of the female partner with a focus on vital signs, including thyroid examination, breast examination, and pelvic examination. Focus on evaluation of ovarian reserve, focus on evaluation of ovulatory function, and focus on evaluation of structural abnormalities. Imaging modalities to detect tubal patency and pelvic pathology and assess ovarian reserve. To obtain the male partner's medical history and evaluate semen analysis parameter, or refer the male infertility patient to a male infertility specialist because they are more comfortable there. Indications for earlier or immediate evaluation include the following: oligomenorrhea or amenorrhea, known or suspected uterine, tubal or peritoneal disease, then stage 3 or 4 endometriosis, if there is known or suspected male infertility, and women over 35 years of age. Now, this is the approach to female evaluation. 1. History taking, physical examination, pre-pregnancy evaluation, then additional evaluation for etiology of infertility, evaluation for diminished ovarian reserve by anti-Mullerian hormone test, basal follicle stimulating hormone, thus estradiol, then transvaginal ultrasonography, antral follicle count. Evaluation of ovulatory function, this function by ovulatory function test, example serum progesterone measurement. Evaluation of tubal factors by hysterosalpingography, hysterosalpingocontrast sonography. Evaluation of uterine factors by transvaginal ultrasonography, sonohysterography, hysteroscopy, hysterosalpingography. Pre-pregnancy evaluation. we have to ask whether the reproductive age patient is currently using any contraception or she is planning for a pregnancy. Pre-pregnancy counseling should occur several times during a woman's reproductive lifespan because health status and risk factors can change over time, maximizing her reproductive and pregnancy outcomes. Chronic medical conditions such as diabetes, hypertension, psychiatric illnesses, and thyroid disorders have implication for pregnancy outcomes and they should be optimally managed before pregnancy. Recommendations for screening are screening for sexually transmitted infections, then screening for the same genetic condition as recommended for pregnant women. All patients should be routinely asked about the use of alcohol, nicotine products, and drugs, including prescription opioids and other medications used for non-medical reasons. Female pre-pregnancy folic acid supplementation should be encouraged and to reduce the risk of neural tube defects. Now, this is very important. While evaluating, it is seen that if we supplement folic acid to the women for at least 3 months before conception, this goes a long way in reducing the risk of neural tube defects. Role of micronutrients and diet. Relevant history. This is the relevant history we take from a patient. One is duration of infertility. How long has she been married? How long has she been trying for the pregnancy? Any past treatment history, menstrual history in detail. How are the cycles? Whether the cycles are regular, whether they are not regular. The length of the cycle, the duration of the cycle, whether the menstrual cycle is accompanied by pain, whether she is giving history of dysmenorrhea, then previous any pregnancy history, past contraception use, history of sexual dysfunction, previous surgical history, any history of hospitalization, history of pelvic inflammatory disease, medical history like thyroid disease, galactorrhea, and hirsutism, history of abdominal pap smears, family history of congenital defects, history of occupation, whether she is addicted to any substances. Now, examination of female partner. General examination. When the patient comes to us, we first ask her age, check her weight, estimate her body mass index, then look for presence of features of syndromes like Turner syndrome or Cushing syndrome. Then examine her secondary sexual characters. Look for hirsutism, look for the presence of acne. Now, this is also very important because many a times when the patients come to us, the face is all clean and clear. We have to ask them whether they have any hair on the upper lips, whether there is hair on the under the chin. Examine the jawline properly for excessive facial hair, and also how frequently does she clean them? Because if she is using a laser technique, then it will require longer time for the hair to grow. Look for pallor. Then breast examination is also very important. Before we write serum prolactin to the patient, examine the breast for any discharges, any secretions from the breast. Similarly, palpate the thyroid gland. Put a hand on the thyroid gland and feel if you can palpate any nodules, if there is enlargement of the thyroid gland, if there is any tenderness of the thyroid gland, and then we go on to write thyroid stimulating hormone test to the patient. Look for signs of tuberculosis, any scars or sinuses if they are present. Local examination is done. Perform per speculum examination, per vaginal examination for any obvious abnormalities like incorporate hymen or rigid hymen, or spasm of the vagina, vaginismus. Look for any malformation, aplasia or hypoplasia of the uterus, aplasia of vagina, transverse vaginal septum. Do a pelvic examination and feel for any adnexal masses, any ovarian tumors. Then look for uterine enlargement. If you can find that the uterus is normal in size or whether you can palpate any fibroids on per vaginal examination. Signs suggestive of pelvic endometriosis in the form of uterosacral nodularity. Now this, when we are taking history itself, the patient will give us history about endometriosis. When she gives history of severe painful menstrual cycles, dysmenorrhea. When she gives history of painful coitus, dyspareunia, or she gives history of pain during defecation, all these will suggest that she might be having pelvic endometriosis. Then examination under transvaginal sonography to confirm these findings. Evaluation of male partner, general physical examination and medical history in detail, semen analysis, scrotal ultrasound, hormone testing, post-ejaculation urine analysis to rule out any retrograde ejaculation, genetic tests, testicular biopsy, specialized sperm function tests. Semen analysis remains the mainstay in investigating male fertility potential. At least 3 days abstinence is advised to the patient before he goes for semen analysis test. And at least 2 serial samples should be assessed in the same laboratory. What do we look for? We look for sperm count, whether it is normal or it is a low sperm count. We look for sperm morphology, whether it is normal or it is a distorted morphology. And for the sperm motility, there should be normal forward progressive motility. Or see if the motility is not normal. What is the WHO criteria? According to the WHO, the lower limit of normal semen testing is the count should be at least 20 million per ml. 40% of the sperms should have progressive motility and 30% of the sperms should have normal forms. Preliminary fertility investigations. Day 2 to day 4, follicle stimulating hormone, luteinizing hormone, estradiol, and anti-Mullerian hormone. Then thyroid stimulating hormone. Transvaginal ultrasonography of the pelvis to look for antral follicle count, pelvic anatomy, and features of deep infiltrating endometriosis. Blood grouping and antibody screening. Full blood examination including rubella, varicella, immunoglobulin G, hepatitis B, hepatitis C, HIV, syphilis serology, then genetic carrier screening if desired for thalassemia, triple screen, Fragile X syndrome, extended carrier screening, transvaginal ultrasonography. This is done for if ovulation induction is monitored to identify ovarian response in natural cycle, IUI cycle, and IVF cycles. Baseline scan is done on day 2 or day 3 of the menstrual cycle. It measures the size of the ovary, the volume of the ovary, the position of the ovary, if there are any cysts or any pathology of the indexa. Antral follicle count is done. Low antral follicle count may be defined as fewer than 5 to 7 follicles with poor response to ovarian stimulation. Antral follicle count may be elevated in women with polycystic ovarian syndrome. Pre-ovulatory scan done on day 9 or 10 of natural or IUI cycle and day 5 or 6 of IVF cycle. Now when we are doing ultrasonography serial scans in the mid-cycle, it will precisely measure the Graafian follicle before ovulation, a size of 18 to 20 millimeters of the Graafian follicle, and endometrial thickness of more than 8 to 9 with a trilaminar pattern is optimum for ovulation. And now when we do the scan immediately after ovulation, what we find is this dominant follicle will be collapsed. We see a collapsed follicle and we see fluid in the pouch of Douglas. The luteal phase scan is done for the assessment of the rupture of follicle, then establish the presence of an adequately functioning corpus luteum, luteal blood flow on color Doppler. Transvaginal scan is also a very good predictor for the prediction of different physiological changes undergoing at the level of endometrium during pre-ovulatory and luteal phase of the cycle. Then 3D ultrasonography. Ovulation predictors are as follows. We have so many ovulation predictors. First is basal body temperature. The woman is asked to take her basal body temperature as soon as she gets up in the morning. She wakes up in the morning before she gets out of the bed. The basal body temperature chart shows a biphasic pattern. After ovulation, there is a rise in the basal body temperature. This continues to remain so, and 2 days prior to the menstrual cycle, there is a fall in the basal body temperature. Then cervical mucus study will show Fern test, as Afroz madam has shown, that cervical mucus is seen in a ferning pattern. This ferning pattern, which was seen in the mid-cycle, it disappears 22nd day after the menstrual cycle, and this predicts ovulation. Similarly, spin-Baki test, the stretchability of the cervical mucus, which was there in the mid-cycle, disappears after ovulation. The cervical mucus can be stretched to about 3 to 5 inches before it breaks. Vaginal cytology shows the features of progesterone effect if there is ovulation. Endometrial biopsy shows secretory changes in the endometrium when it is done after ovulation. There is the earliest sign of ovulation is pre-nuclear vacuolation, and this change in the endometrium is because of the effect of progesterone on the estrogen primed endometrium. When do we do the endometrial biopsy? It is recommended 21 to 23 days after the menstrual cycle. And we have to give barrier contraception to the female to prevent accidental conception. Or if the cycles are irregular, endometrial biopsy is done within first 24 hours after the beginning of the menstrual cycle. Mid-luteal serum progesterone A concentration greater than 3.0 nanogram per ml in a blood sample drawn between days 19 and 23 is consistent with ovulation, whereas a concentration of greater than 10 nanogram per ml implies that there is adequate luteal support for the patient. Ovulation predictor kits are available. This will detect the LH surge. It detects a rise in luteinizing hormone in the urine. Begin testing 3 to 5 days prior to the expected date of ovulation. A positive result means that there will be ovulation in the next 24 to 36 hours. Ultrasonography is also a very good predictor for ovulation. Diagnostic tests, assessment of ovulatory function. Mid-luteal phase serum progesterone level, if it is more than 3 nanogram per ml, is evidence of ovulation. But if the level of progesterone is less than 3 nanogram per ml, this indicates anovulation. Then you evaluate for causes of anovulation by serum prolactin, TSH and FSH level. Urinary LH surge, if positive, indicates ovulation. Assessment of ovarian reserve, day 3 FSH is done. If this is less than 10 milli-international units per ml, this indicates adequate reserve. A level of 10 to 15 milli-international units of FSH shows that there is borderline ovarian reserve, and a level of FSH more than 20 milli-international units per ml indicates poor reserve. Day 3 estradiol, if it is less than 80 nanogram per ml, shows adequate ovarian reserve. Anti-Mullerian hormone of a level of 0.5 to 1 nanogram per ml predicts low ovarian reserve. As Ranjan madam has said that if the level is more than 2.5, it indicates adequate ovarian reserves. AMH is absent at menopause. It is not detected at menopause. This is the investigations, lab investigations and diagnostic approach for evaluation. History, physical examination and basic examination. We have seen about the ovulatory cycles. This is about the anovulatory cycle. Endocrine evaluation for FSH, LH, dehydroepiandrosterone S, then TSH and serum prolactin. For the tubal factor evaluation is endometrial biopsy, hysterosalpingography, hysterosalpingocontrast sonography, laparoscopy with dihydrogenation test, and hysteroscopy. Then for the cervical factor, postcoital test is advised. Postcoital test is done 8 to 12 hours after coitus, and if you find at least 10 actively motile sperms per high-powered field, that indicates a satisfactory PCT. But postcoital test is not recommended anymore these days. PCODs, I'm not going to talk in detail because we have the next topic coming on PCODs. If you find during sonography ovary with multiple small sub-centimeter sized follicles, appearing in a necklace pattern. This shows that this is a polycystic ovaries. This will lead to anovulation, which is a cause of infertility. Tubal evaluation by hysterosalpingography is done to assess the shape of the uterine cavity and evaluate tubes. For the assessment of the shape of the uterine cavity, it will show whether the uterus is normal in size, whether it is arcuate, whether it is a biconvate uterus, or it is a septate uterus, or it is a subseptate uterus. It will also show intrauterine adhesions. Then to evaluate the tubes, it is done for assessment of tubal abnormalities like tubal occlusion or tubal irregularity. When the tube is seen in a beaded pattern, this shows that there could be pelvic tuberculosis. Then for peritubal abnormalities, tubal spasm. If the uterus is normal in size and both the tubes are open, then when you are doing hysterosalpingography, there will be free spillage of dye from both the tubes. This indicates patent fallopian tubes. Hysterosalpingography precisely shows the side and the site of the tubal blockage. Whether the right tube is blocked, whether the left tube is blocked, the cornual end is blocked, the femoral end is blocked, or the ampullary end is blocked. Hysterosalpingography is less invasive and it is cost effective. Although hysterosalpingography is of a low sensitivity, its high specificity makes it a useful screening test for ruling in tubal obstruction. In case of an abnormal finding, diagnostic laparoscopy with dye transit is the procedure of choice. Hysterosalpingography is cheaper. It is performed as an outpatient procedure. Although it is often painful, it has a low incidence of complications. But at the same time, it carries the risk of radiation along with it. Now, tubal evaluation by hysterosalpingo contrast sonography. Sonohysterography is the visualization of the uterus and the adnexa ultrasonographically with the infusion of fluid to a transcervical catheter. Using sonohysterography, the uterine cavity usually is easily defined and abnormalities such as endometrial polyps, submucosal fibroids, and intrauterine adhesions can be seen. More than 16% of infertile women and 40% of women with abnormal uterine bleeding will have an abnormality on sonohysterography. Sonohysterography has a sensitivity of 91% and a specificity of 84% for the detection of intrauterine structures. Tubal evaluation can also be done by hysterosalpingo contrast sonography with automated 3D coded contrast imaging technology. Then, other method for tubal evaluation is laparoscopy with chromopertubation. We have seen these, so I'm going to skip this evaluation of female infertility flow chart. Other tests, hysteroscopic evaluation to evaluate the condition of the uterine cavity, whether there is any polyp, submucous fibroids, intracavitary lesions, intrauterine adhesions, then Mullerian duct anomalies like uterine septum, endometritis. Laparoscopic evaluation is the gold standard for tubal evaluation, but it is only to be done when you find that the male factor is normal or it is corrected, or the ovulatory function is normal or it is corrected. Laparoscopic evaluation is done for two purposes. One is diagnostic laparoscopy, the other is operative laparoscopy. Diagnostic laparoscopy you do when you find an abnormal finding on hysterosalpingography or in cases of unexplained infertility to check the patency of fallopian tubes, especially in unexplained infertility, tubal adhesions, to evaluate pelvic diseases, then for endometriosis, grading and treatment of endometriosis, to look for ovarian pathology and uterine fibroid if it is distorting the cavity, then for Mullerian anomalies. Operative laparoscopy is done for ovarian drilling, for reconstructive tubal surgeries, then for fulguration of endometriotic implants, as Ranjwal madam has said, and it is done for adhesiolysis. Then it is also done for gift and zift procedures, gamete in fallope transfer or zygote in fallope transfer. Indication of MRI in female infertility. This is a non-invasive radiation-free modality. It is done for complex adnexal deep-seated endometriosis, mullerian duct anomalies, adenomyosis, fibroids, pre-surgical mapping and location, and vascularity of fibroid, intrauterine adhesions, pyosalpinx. Cornual fibroid is also very clearly seen on MRI. MRI is superior to ultrasonography in determining both tubal and peritubal component of pelvic inflammatory disease. In the era of evidence-based medicine, MRI has an indispensable role in diagnosis and management of female infertility. Thank you. This is all from my side. Thank you for the patient listening.
Thank you, ma'am. Any point of discussion? I request Dr. Tuba Madam to kindly felicitate. Not taking our journey forward, coming to the female pandemic that is uprising, polycystic ovarian disease. We have a gem from GMCH Aurangabad and GMCH Ambajovai. She has worked with Dr. Perry Jula for 5 years and running a successful maternity hospital director from Farah IVF Center and Maternity Hospital. I call upon Dr. Farah Dibaman to kindly give us a talk on polycystic ovarian disease.
Assalamu alaikum everybody. A very good afternoon also. I am very thankful to Shafi sir and the organizers of the CME to invite me here in front of you all. The topic which is given to me is polycystic ovarian disease or syndrome, and as rightly said, it is really a pandemic now because in the practice of infertility, I think more than around practically when we see more than 50 to 60% of the infertile people, ladies coming to our anovulatory diseases coming to the OPD are belonging to the PCO group of people. As soon as the girl enters the consulting room, looking at her only, majority of the times we can understand that this is a PCO patient. So worldwide, if we see, it is said that around 4 to 10% of reproductive age group ladies suffer from PCOD. But I feel it is more now. I think all of us would agree, whoever is practicing the gynecology. Now, to understand the PCOD, current perspective of PCOD is the current perspective of PCOD. It is not just a disease as such where one or two things are there. It is considered as a metabolic syndrome, like we do for diabetes, type 2 diabetes, and cardiovascular disease. It is a constellation of so many things which give rise to the signs and symptoms which we get in a lady who is typically showing all the signs of a PCOD. The most widely recognized definition. Now, first thing is we have to come to a definition. How to define when to say that a girl is having PCOD or that lady is having PCOD. So it was the Rotterdam criteria are still followed, which say there are three things, out of which even if two are there, we can label the girl as a patient as polycystic ovarian disease. First is hyperandrogenism. Hyperandrogenism, it can be clinical or biochemical. Clinical, I'm not following the slides very properly. So first is hyperandrogenism. It can be clinical hyperandrogenism or biochemical hyperandrogenism. Clinical hyperandrogenism is quite obvious, like we'll see hirsutism, acne. Sometimes we see male pattern balding, or there can be obesity. Especially central obesity we are seeing in PCOS. Second is oligo or anovulation. Now, when do you say that this lady is oligo-ovulating or anovulating? Ovulation is in a year if she has less than 3 cycles, or if she has around six months of amenorrhea, then we can label it as oligo-ovulation or anovulation. And third is ultrasound appearance of PCO ovaries. When we do ultrasound, when do you know that this is a polycystic ovaries, what we are seeing, or this is a normal ovary, or just because there is some overlapping. Very young girls in their in young age, there are a lot of good number of follicles. So sometimes there is a overlapping. We can call it multicystic, or especially in young girls. So polycystic ovaries we define when each ovary is having 12 or more follicles at least, and the size is 2 to 9 mm size of follicles. And volume, they say it is more than 10 cc volume, then we can label it as polycystic appearing ovaries. So out of these three, even if two are there, we can label the patient as patient of polycystic ovaries. Now, when we have seen, once we have diagnosed, a girl has come, we have diagnosed this girl as a polycystic ovarian patient. So, little going into the theory part, that is pathophysiology. How does this happen? Why is the ovaries becoming polycystic and manifesting all the symptoms what the girl will present with? So first is there are theories still. We still are not very sure that what comes first. It is like whether the hen comes first or the egg comes first. So first is insulin resistance. It is said that the crux of the problem starts with insulin resistance. Now insulin resistance, it is the mechanism how it goes is insulin resistance increased glucose levels in the blood. Increased glucose levels goes to the pancreas. Pancreas will increase insulin secretion, causing hyperinsulinemia. Hyperinsulinemia goes to the theca cells of the ovaries. Theca cells have insulin-like growth factor receptors, giving rise to increased androgens. Because as we all know, theca cells are responsible for producing androgens. These androgens go to the liver, and even insulin, when there is increased insulin secretion, hyperinsulinemia, it also affects the liver, and from there is reduced sex hormone binding globulins. Reduced sex hormone binding globulins give rise to free androgens, because androgens are not bound to sex hormone binding globulins and they are free androgens. So this again gives rise to hyperandrogenemia. This is one thing. Second is LH excess. When we see PCO ovaries, there is LH excess when we do blood tests for hormones. Luteinizing hormone is more and FSH is reduced. Like when we say there is reversal of LH ratio. LH goes high and FSH goes low. For the cause for increased LH is also very much not sure. Something, so there is some mechanism from the hypothalamus giving rise to more levels of LH. When there is more rise of LH, there is anovulation, and because of chronically elevated estrogen levels, FSH is not rising because of the negative feedback effect. So FSH is less, LH is more. Where is this estrogen coming from? Estrogen is coming from aromatization of androgens in the body. These are the two main things. Third thing, which is little new these days, is the gut-brain axis and PCO. It's not there. Gut-brain axis and PCO. It is said that now, I think many of us must be knowing that so many theories have come about the gut health, which is affecting it's also the basis for so many things, for even the mental health. I think Dr. Sana must be agreeing. And diabetes also. So gut-brain axis is a bidirectional communication pathway between the gut and the brain. It is thought to play a role in PCO by influencing insulin sensitivity, androgen levels, and inflammation. Women with PCO, it is seen to have it's seen that they have different gut microbiota as compared to the normal healthy females. The gut microbiota can produce short-chain fatty acids, which can improve insulin sensitivity and induce inflammation. The gut-brain axis is so looking into it now. New promising therapies have come where they have modulating the gut microbiota for the treatment of PCOS. So this is in short the pathophysiology to understand why a patient will have PCO ovary. Now, diagnosis, lab investigations, if we see, generally, in practical, what we do in the OPD, like Ishrat Madam must have said, that all hormonal investigations are done, especially according to the clinical presentation. Specifically for PCO as such, there is there's no blood test as long as practically what we do in our practice. One thing is we can go for blood sugar levels, HbA1c, because it is seen that PCO people have a high chance of insulin resistance and so to diabetes. HbA1c, thyroid, various serum prolactin, LH, FSH, and everything is done. Important is AMH. AMH is also, practically how much it helps to diagnose is not very. When we see ultrasound of PCO ovaries, it itself indicates that AMH must be high. But still, as a protocol, we do AMH, what practically is done with PCO patients. Now, practically, when a patient is coming, now we are more interested in the management, how to manage this patient. First thing is if the patient is obese, which is generally the cause. Like in PCO, almost 50 to 60% patients are obese. Whereas if a patient is obese, there is a chance of 50 to 20% only that she can be a PCO. It's not true vice versa. I've seen so many obese ladies, 100, 110, 20 kgs also, but they don't fit into the category of PCO. They are normally ovulating and they conceive also properly and everything goes well. So it's still in management of PCO, because there are still two types of PCOs as we see. There are obese PCOs and there are lean PCOs also. Obese PCOs are seen more to be on the side of insulin resistant cases. The management, what we practically do, I am not very much going with the slide. Shafi sir has helped me a lot with the slide. Management, what we do, I think is practically the OPD, I could say that. So first thing is weight loss. Weight loss is a very important aspect. As all of us gynecologists will agree that even if 5 to 10% of weight loss is there, this gives rise to lot of changes in the ovulation pattern. Girls, they go back to ovulatory pattern quite easily if they lose weight. I know weight loss is very, very difficult. So very difficult, especially in PCOS because it is also hormone dependent, but it helps a lot. And we see a lot of girls who are very determined and they really do lose weight, and it gives. Even non-pharmacologically it helps without medicines, and even if we are giving the medicines like whatever treatment we give, it becomes more effective and we need less of dosages and good results with with pharmacological treatment if there is weight loss. Weight loss, then exercise. One thing is the sleep-wake pattern also, but I feel that these days is our young generation, they are sleeping around, now I'm generally asking 80-90% of the people, they sleep around 1 or 2 o'clock at night. And there is a theory that because of the chronic stimulation of the pineal glands, there is some amount of hormonal imbalance which gives rise to ovulatory dysfunction also. So that is the reason we have started with melatonin, and these drugs have come which will increase their sleeping. The hormonal imbalance will be corrected to an extent. Now, proper pharmacological treatment depends on what the patient needs. Sometimes it's just an adolescent girl; she just wants regularization of her cycles. As we all know, for about 2 years after menarche, the hypothalamo-pituitary ovarian axis is not very mature. So there are, even if the patient girl is having irregular cycles or like that, I think only wait and watch can go. If she is not having any menorrhagia and it is not posing any health hazard to the girl, we can wait and watch for around 2 years. After that, that is one thing. Then if the girl, she is not interested, sometimes there are girls who are not interested in fertility, but they want regularization of the cycles. So for regularization of cycles, OCPs can be given. These will, the HPO axis, the LH-FSH ratio is regularized pills. So 3 to 6 months of OC pills, especially anti-androgenic, are better because the acne and hirsutism, which is related to PCO, can be reduced with the OC pills. So 6 months we can go for OC pills, especially drospirenol containing and spironolactone containing the OC pills are good for cycle control. And after 6 months, if the patient doesn't want OC pills sometimes obese people, OC pills can give rise to insulin resistance also. It increases insulin resistance a little bit. So for that, if the patient misses a cycle, we can just give a course of progesterone for 5 to 6 days, like from 21st day to 25th or 26th day, and she can get a withdrawal because of with the progesterone combination. These are the two things which for regularization of menses. Then for comes the part infertility, because generally we have seen anovulation PCOS, and because of that there are difficulty for conception. For treatment of infertility, there are a few drugs. The first, earlier, a few days back or few years back, clomiphene citrate was the only thing which was used, and still few people use. But now letrozole has come, which is considered a better option because it gives rise to monofollicular development. Letrozole is a type of aromatase inhibitor. Now we know how the estrogen is produced. Like cholesterol is converted into androgens. Androgens are converted into by aromatase enzymes. Androgens are converted into estrogens. What letrozole will do is that will block the aromatase enzyme and reduce the estrogen production. As estrogen production goes down, the negative feedback to the brain, to the anterior pituitary goes that estrogen is less, so FSH will be reduced. FSH released at a higher level, that will give rise to follicular development. It acts on the follicle in the ovaries, and there is follicular development because of the raised FSH. So coming to what exactly and the dosage is, we start letrozole from the second or third day of the cycle. If the weight of the patient is less than 60 kgs, generally we give 2.5 milligram daily for 5 days, second, third, fourth, fifth and sixth day, or from third to the seventh day. And we see for follicular study, on around the 11th or 14th day of the cycle to see if letrozole 2.5 milligram is enough or not, if the growth is there, endometrial growth is there, or and the follicular growth is also there or not. Suppose we find that for a patient who she is not responding to 2.5 milligram, we can increase the dose to 2.5 milligram twice daily. That goes to 2.5 milligram. That goes to total 5 milligram daily instead of 2.5. Dosage of letrozole can be even stepped up to 7.5 milligrams also. So there are a few regimes, protocols you can say, where they give 2.5 first day, 5 milligram third day, second day, like that they step up the dose. It depends on the experience of the treating doctor, whatever she has, and every patient is responds differently. So 1 or 2 cycles of the patient, sometimes we just it is utilized just to understand that what the patient needs, basically what she responds to. So with letrozole we can with follicular study, then if the follicle is growing well at around 18 mm and if the endometrium is around 7, more than 7, or the best thing is it should be 8 millimeters, then we give a trigger if she is, but triggering here in PCO is very important. That is the next topic for ovarian hyperstimulation syndrome. Ma'am will speak about that. So we can trigger her with HCG, and either we can go for planned relations, or we can go for IUI, whatever is decided with the patient, depending on that. So letrozole right now is the first main treatment line to start with for a patient with polycystic ovaries. Some people give clomiphene also, that is also not wrong. The only thing is letrozole being short acting, the duration of action of letrozole is not so long as clomiphene. So generally it just recruits one follicle and then it dies. So monofollicular development is more seen with letrozole. But clomiphene is long acting, so it will keep on recruiting a little more follicles. So multifollicular growth is more seen with clomiphene citrate. With clomiphene also the same dosage is different, but the pattern is that only second or third day of cycle we start with 50, or if we feel that the patient doesn't need 50, we can go to 25 also, 50 or 100 also, 100 milligrams of clomiphene citrate from day 3 to day 5 and for 5 days. And the same thing we follow with follicular study and endometrial growth. Difference between letrozole and clomiphene, that is what I said, that this letrozole will be better because it gives monofollicular and clomiphene will give more follicles. So it is better for a monofollicular because this will give rise, there are less chances of hyperstimulation also with letrozole, and multiple pregnancy rate also is less with letrozole as compared to clomiphene citrate. When it comes to mechanism of action of clomiphene citrate, it acts more on the it is a selective estrogen receptor modulator drug which competitively blocks the estrogen receptors. So same, the hypothalamus pituitary axis, it feels as if the estrogen is less and then FSH is released more. This high FSH will act on the follicles and give rise to follicular growth. Now, the first thing is why in polycystic ovaries there is no follicular growth. All the pattern what we see is all the follicles come from 2 to 9 centimeters and they get arrested over there. Why do we need induction of ovulation? This is seen because of androgen excess in the ovaries. Whenever there is androgen excess, that will not allow the follicle to grow and cause apoptosis of the follicle. So generally these follicles go to a stage that is apoptosis of the follicle and the remnants they are all there. Like what we see in polycystic ovaries is we see a thick stroma and the volume of the ovary also increases. Third management point, with clomiphene we can add metformin also because metformin is known to help insulin resistance. So metformin also we can add 500 milligrams twice daily, or sometimes we need 1 gram also. Insulin sensitizers are there, myoinositol, chiroinositol. These are some studies say they help, some studies say they don't help. Letrozole and clomiphene we can add along with injection HMGs also. because suppose she is not conceiving, there is no response with letrozole, no response with clomiphene, we can shift the patient. Either there are two things now. We can go for a PCO drilling, which will reduce the androgen levels in the cortex. In PCO drilling, we do it laparoscopically, where we just cauterize the parts of the we cauterize the ovary, and because of that the androgen levels come down, the LH levels also come down, and that helps in restoration of normal ovulatory follicles, normal ovulatory cycles. The thing with PCO drilling is that while doing PCO drilling, we can also evaluate her pelvis, we can evaluate her tubes, the patient's tubes, cervix. Along with that, we can do hysteroscopy also. So her complete infertility workup is also done. So we can go for drilling. Drilling was more common a few years back, as all of us would agree, but nowadays drilling is not that commonly done as compared to the earlier days. Because around 10 years back, I used to see they used to drill the ovary all around. But now it is restricted, because that may give rise to ovarian failure also. If we destroy more of the follicles, that can give rise to ovarian reduced ovarian reserves also. So ovarian drilling now, even if we are doing, it is restricted to around 4 to maximum 5 punctures per ovary. Second, after drilling, it is seen that for a few months she gets a lot of girls get regularization of the cycles and ovulation resumes back. But this is a temporary method. It's not that once in life you do a PCO drilling and then finish it is, or now so she will never get PCO. It is not like that. It is seen that first 6 to 7 months it gives best results, but after that again the same pattern. I have practically what I have seen, and it is said also that it comes back. Then another option for ovulation induction. Suppose the patient is not ovulating with letrozole, she is not ovulating with clomiphene. We can start her with injection HMGs, human menopausal gonadotropins, or gonadotropins like some people like to use only FSH. So either ways we can go. Same protocol in that also. From second day we start with HMGs. To start with human menopausal gonadotropin, it is better to use the lowest dose, because PCO patients sometimes they give hyper response. Lot of follicles may grow, and then we will be in a dilemma to what to do with so many follicles. Or sometimes we may need to convert that cycle into an IVF cycle, and patient may not be prepared for that. So we can start with, theoretically they say 37.5, but I have never practically seen anybody giving 37.5. Generally, at least we start with 75 international units. And follicular monitoring, if the follicular growth is good, if we see good follicles 18 mm and endometrium correspondingly good triple line, then we go ahead with the trigger and either timed intercourse or IUI, whatever the patient needs, and depending also on the male factors. It is generally, now when we are spending so much on injectables, so it is recommended, and I also feel that better to do IUI, which will marginally increase the success rate of the patient. So, and the new thing which is coming is the gut microbiota changes. They are talking about fecal implants and all like that, but it is new. We have also added this pre-probiotics in our practice also, but let's see how it works. So this was about the management part for infertility, for irregular cycles, and the long term during pregnancy, these girls become pregnant. If this PCO patient, there is seen that because of the hormonal imbalance, there are high chances, a little bit more, like marginally as compared to the others, because of the hormonal disturbances, because we are creating a hyperestrogenic, hyperestrogenic and androgenic milieu inside. So there are a little chances that corpus luteum may not be very good, it may not function that very well. So it's always good to give, whenever we are supplementing letrozole or clomiphene. There is a school of thought, they say that even if you are giving letrozole or clomiphene, there is no need to give a luteal phase support. But it is always good to give a luteal phase support, because that will not cause any harm. Generally, when we have used so many drugs, it can give rise to not so good corpus luteum in terms of its function. So it's always good to give progesterone support, luteal phase support, in the form of you can give vaginal capsules. Oral is causes a little disturbance to the patient, so generally vaginally good products are available. You can use progesterone gels, you can use progesterone capsules vaginally or injectables also. And sometimes we go for agonist support also. Once these girls become pregnant, there are more chances that I've spoken before. There are little chances of abortions also, and when the pregnancy progresses, maybe that patient may, because of her obesity and all these things, there are little more chances of landing up in PIH, IUGR, or gestational diabetes or frank diabetes. So these people will have to manage them by the obstetrician accordingly. After this, the long-term problems with PCOD. Long-term problems with PCOD, there is a subset of these people who may go to develop diabetes mellitus in their later life. There are more chances as compared to the routine ladies. And because of the unopposed estrogen activity, which these girls get exposed to, there are more chances of getting CA endometrium or a little more chances of getting CA ovary also because of the infertility part, because of unopposed estrogen. Because there is no ovulation, only estrogen is working. After ovulation, as we all know, we get the corpus luteal cyst, and corpus luteal cyst will give rise to progesterone. So unopposed estrogen is acting. That's why they are not getting their cycles. And unopposed estrogen may give rise to endometrial hyperplasia, which may, if not addressed properly, which may lead to CA endometrium in later life. So this is all what practice. I didn't go with the slides. Basically, I don't know what practical. I hope I was not very fast.
Thank you.
That there is a hyper
Yes.
clinical biochemical evidence of that. Now that might make one think that such a woman would rather be like to be a man. She may not be interested in motherhood herself. One. Second, there may be an gender identity crisis. What we see as a male within a family. Is it so?
So hyperandrogenism is not to that extent that it will totally change her mental makeup and everything. It is not that much. That level of hyperandrogenism is seen in androgen-produced tumors and virilizing tumors and like that. With PCO, it's not that high. If it is a high testosterone or anything, then you have to see other causes of androgenism, virilization and all. So many other causes, and we have to rule out all other causes of. Practically speaking, I don't think they should. Do you do androgen levels in the OPD for PCOS?
No.
No, we generally
If I
don't.
know the patient has marked hirsutism, we just do a serum testosterone level. If a serum testosterone level is more than 200, that goes in favor of androgen producing tumor. Then we need to do CT, MRI searching for an ovarian tumor or adrenal tumors.
Actually, what was the premises was, she said
Yeah.
that many of the patients are reluctant to actually do something for their obesity. They do not suffer from that.
Obesity.
So, obesity, while the instinct of motherhood is very strong in women. So, on basis of that premises, I was actually asking her,
No,
does
sir.
it work in some way?
Sir, suppose she is newly married, and what practically I'm telling you what we see. She may not be married. She is waiting for her marriage. Parents come with a concern that our daughter is having all these things. She's becoming obese. She's getting hair growth. She's not getting her cycles regularly. So this time she is not interested in her fertility. No? Forcefully or whatever her instinct is saying, but at least at this time she is not interested in fertility. So we have to take care of all this. And nowadays the newly married girls sometimes they are not planning right away after marriage. So as soon as the patient comes with PCO, we feel okay, we'll start with. She said, no, madam, I'm not interested in fertility. Just give me something for regularization of my cycles. We are postponing our fertility later on, later. So these people come into that category. Thanks.
Thank you, madam. On behalf of Elite Academy, I would like to add, due to a technical glitch, madam was not able to follow her, PowerPoint presentation. But it became a bloom that we have got the discussion of what she is actually practicing, and that is the crux of organizing such.
At the moment also I was worried that I don't know, and I thought it's better to talk like whatever we are doing so that everybody gets some practical things to get, what we can utilize in our day-to-day practice.
So thank you very much. I call upon Dr. Nafis Fatima Madam to kindly felicitate Dr. Faradi. She is senior gynecologist.
She's my classmate.
Okay. Huge academic feast from all the gynecologists in the town. Let's give it a break and call a psychiatrist. So, Dr. Sana Khilji madam, she is MBBS from GMCH Aurangabad and done her DNB in psychiatry. And I have a list of certificate courses what she have done, but at this point I would like to highlight some. She has got her certificate courses in women mental health. She has got certificate courses in addiction psychiatry and also in child psychiatry from NIMHANS, Bangalore. Madam is practicing psychiatry in Aurangabad from 2011, and a good news is they are about to establish a hospital of Women Happiness Center at Kanchanwadi. At this point, I think Dr. Erar sir will be, sir, they are establishing a hospital on Women's Happiness Center in Kanchanwadi. So I would request Dr. Faisal Khilji sir to kindly establish a hospital for men health center also. Because just on a lighter note, since morning we are getting bombarding from everyone. Madam is author for many good literature work. She is having a women's psychiatry ward and Know Your Child is one of the article madam is having, and Hum or Hamari Nafsiya. That is, I call upon madam to break the silence. Vaginismus, its impact on women infertility.
So it's break the silence or break the monotony, whatever you say. The topic is against the regular stream. It's vaginismus. It's a psychiatric condition that I would say, but patients usually go to gynacs. They get treatment from multiple gynacs. Finally, a gynac refers them to a psychiatrist. Or very few patients these days, today they have Google. they have the information on the net, they search and they see a psychiatrist. That's how it is. And you were telling Men's Happiness Center, yes, that's also in pipeline. Inshallah, in 2 years. No. So I know his plans, that's why I'm telling on his behalf. So, what is vaginismus? It's an involuntary tensing or contracting of the muscles around the vagina. The contraction is usually in the outer lower one-third of the vagina. These are unintentional automatic muscle spasms that occur because of fear. When either a penis, a finger, a tampon, a medical instrument, anything is attempted to penetrate inside the vagina. Sometimes they are uncomfortable, sometimes it's very, very painful for the patient. It usually involves the vagina muscles do not contract on their own. The reason of their contraction are the negative thoughts and beliefs about sexuality and sexual intercourse. Brain is responsible for vaginismus and not vagina. Name of the sexual dysfunction must be brainismus, not vaginismus. So, who might get vaginismus? I already told, like, the patients come to either gynecologist or psychiatrist, and usually they consult for non-consummation of marriage or infertility. That is the primary complaint. And some women can have vaginismus, or we call it dyspareunia, in later life also, after having a normal course for the initial years. First, you need to rule out the other causes of painful intercourse, whether it's due to lack of sexual arousal, vulvovaginitis, atrophic vaginitis, vulvar dermatosis, drugs, radiotherapy, endometriosis, or PID. Once you've ruled out this, then the cause is vaginismus. Means the cause is psychological. You need to look in for predisposing factors like whether there are any anxiety disorders, whether there's history of painful sexual intercourse, painful pelvic examination, history of sexual assault or childhood abuse is very, very important. No one will give you this history on day one, but gradually rapport has to be established with the patient, and over a duration, you get this history, and all this has to be reconstructed. You get this history very common in patients with vaginismus. Precipitating factors could be PID, gynecological surgery, urogenital atrophy, and maintaining factors when a couple continues to tries to have intercourse despite of the pain. This reinforces the spasm of the musculature and it maintains the pain. As per American Psychiatric Association, in the DSM criteria for diagnosis of mental disorders, DSM-5, vaginismus and dyspareunia have been put together as a single diagnostic entity called genitopelvic pain or penetration disorder. Part of the spectrum of painful intercourse, the difference being a matter of severity. What are the symptoms and causes of vaginismus? Tension and anxiety about the sexual act can lead to painful intercourse. Women tend to involuntarily control their pelvic floor muscles due to tension. The pain is real and makes intercourse pleasant or unbearable. Anticipation of further pain may cause women to avoid intercourse altogether. If a partner proceeds the intercourse regardless of women's state of readiness, the condition is aggravated. The causes could be physical or emotional. Emotional causes, like I already told you, past traumas like sexual abuse, painful sex in the past, strict upbringing where sex is not discussed or seen as a taboo, fatigue, fear, reservations. Physical conditions I will not go into. While taking history, you need to go into medical history, psychosocial history, sexual history, including any episodes of traumatic sexual experience, a clear description of the pain, fear, and avoidance responses you'll get, and you have to find out on history women's ability to tolerate genital exploration by herself or another. And on history, you'll get severe pain during intercourse or intercourse becoming impossible. Classification, Lemont and Passik's classification is there. Stratifying the severity of vaginismus, success in treatment is related to the severity. It depends on the degree of vaginal spasm and degree of fear and anxiety. The grades of vaginismus, Lemon's grade 1, patient is able to relax for pelvic examination. The patient complains of pain but is able to relax. Lemon's grade 2, the patient is unable to relax. When you examine the patient is unable to relax, it's very uncomfortable. Lemon's grade 3, the buttocks lift off the table, the patient retreats. Is not cooperative for examination. Grade 4, there's generalized retreat. And buttocks lift up, thighs close, patient retreats. Passive grade 5, you must have all seen all these patients. And grade 5 is I usually get grade 5 patients. They are generalized, there's generalized retreat as in level 4, plus you get visceral reaction. And one or more of the following symptoms like palpitations, hyperventilation, sweating, severe trembling, uncontrollable shaking, hysteria, wanting to jump off the table, feeling of becoming unconscious, nausea, vomiting, and even a desire to attack the doctor. I had a patient a few days back. Whenever her husband used to approach her for intercourse, she used to have hiccups constantly. That is what we call conversion or hysteria. One more patient was there, she used to get panic attacks, palpitation, breathlessness. One patient, she would have pseudo seizures. All these in the past few days only, I'm telling. She used to have pseudo seizures, she used to just become unconscious, clenching of teeth. All this used to occur before that. And when you go to the history, you explore, you find out there's severe vaginismus. I'll be discussing two short cases. Case 1, 24-year-old female married since 3 years. She had non-consummation of marriage till now. She went to 5 gynecologists. All the gynecologists told her that it is vaginismus. And she underwent 2 surgical procedures, but finally there was no improvement, and one of her gynecologists referred her to a psychiatrist. And after multiple sessions of psychotherapy, there were lots and lots of interpersonal issues. They had to be sorted out. Some anxiolytics were given, followed by graded exposure with dilators, followed by sensate focus, which was followed by couple therapy, which was followed by clitoral biotestimiometry. And her husband was very, very cooperative and understanding and supportive. He would follow all the instructions we would tell along with his wife. So the condition improved only with this treatment, and she's having a happy married life now. Case 2, a 27-year-old female married since 4 months was brought by her parents. Her husband and her in-laws told her parents that we are going to divorce your daughter now because of non-consummation. And it's 4 months since marriage, she's not allowing her husband. So now her parents brought her and they were like, do anything, but we want to treat this condition. And they consulted a bunch of gynecologists also before that. All her gynecological examinations, reports, everything she had, everything was normal. And she was prescribed some medications also, but that did not help much. And finally, she came to me, and on history, it was again fine case of vaginismus. The cause was psychological. On doing a pelvic examination, she had severe pain. She would not even allow inserting a finger. And after a few sessions of psychotherapy, sex education, she would allow inserting a finger with little pain. Her in-laws, in the middle of the therapy, her parents brought her in-laws, and they were like, we'll give you maximum 1 month. And in that, we're going to divorce her. Or we have no issues with the girl. The girl is very nice. We are happy with the girl. And the girl was also happy with her in-laws and everyone. And this was her second marriage. Before this, her previous marriage had also failed because of the same reason, vaginismus. And she would not allow her husband. And now her parents are like, we cannot go on getting her married again and again. And so we need treatment for this at the earliest. And now, after 15 days of therapy, she would go with the first dilator, with a lot of counseling, psychotherapy sessions, and everything. Second dilator also, she would go easily, but after that, she said, no, I cannot go beyond this. And then I decided, like, I told her parents, this is going to take time because she's a case of severe vaginismus. If you give me a few more months, it should work with dilators alone. But on the short notice, it's difficult. So then, under GA, we gave her Botox. And with Botox, we inserted the final dilator. And after that, on day 7 to 15, she started inserting the dilators on her own. We advised her, and she could insert all the dilators, even the last dilator, on her own without pain. And finally, she and her husband also was brought into therapy, and then both of them, they are having a nice, happy married life and sexual life together. When should women be referred? When there is history of sexual trauma, or you find symptoms of anxiety, or when you examine, do pelvic examination, there's phobic resistance, you find, or there are other mental health problems or relationship issues, you should refer them to a sex therapist or a psychiatrist. When the patient is less anxious, vaginal dilators with support from the doctor usually help. Treatment is a team effort. The lines of treatment are, the very first thing you have to do is exploration of phobia. Whether there's history of phobia, what are the false beliefs, you have to go into that. Then sex education about the anatomy, the physiology. Then teach them control of muscles, adductors, relaxation exercises for pubiococcygeus. These are just the psychoeducation part for the patient. And then you come up to systematic vaginal desensitization with the dilators or Botox. Vaginismus treatments focus on reducing the reflex of your muscles that cause them to tense. Treatments also address anxieties or fears that contribute to vaginismus. Kegels exercise, everyone knows here, so you need to teach that to the patient. These dilators are available on Amazon. Anyone can, you can ask the patient to bring them, or you can give it to the patient. Vaginal dilator therapy, these dilators are tube-shaped devices that come in various sizes. The primary purpose is to stretch the vagina. People with vaginismus use dilators to become more comfortable with and less sensitive to vaginal penetration. And usually it's applying a lot of gel or oil before inserting the dilator inside. Gradual, usually it's starting with the smallest one and over few days or weeks progressing to the maximum size. It usually requires up to 2 to 15 sessions, and initially it is done by the doctor, and later the patient is asked to do it herself. And in the third step, the husband is brought into picture. He is asked to do the dilators. Biothesiometry. This is again a new thing. It really helps. It's basically fear. To get over that fear, what you have to do is, you have to, the patient side is, it's all very painful, from pain to pleasure. It's clitoris stimulation is done using biothesiometer, and dilators are inserted. Botox, this is again there in therapy. This is for very severe vaginismus. What it does is it paralyzes the muscle or causes temporary weakness lasting usually 3 to 4 months. So it becomes easier when you have, like in that case, it was at a very short notice. You don't have a choice. Usually at 3 sides on the left, 3 sides on the right, it is injected. And I won't go into the procedure. And usually at the end, and it's given under anesthesia. Anesthetist has to be there because the patient won't be able to tolerate be it the injection or be it the dilator. So, and usually after 2 to 7 days, the results become apparent. It's usually given in the bulbospongiosis, sometimes in the levator MI. It's usually given at 3, 4 and 5 o'clock. 6 o'clock is never used. 7, 8 or 9 o'clock positions. And the major risk with this is there's rectal incontinence. If it's given by an untrained person, you can have rectal incontinence or urinary incontinence for 3 months. Along with this, the patient is usually, it's basically a phobic reaction. Anxiety response, fear response. So we need to give some medications to relax the patient. Some anti-anxiety, some sedatives, some antidepressants, depending on what the symptoms are. And this is the mainstay throughout the therapy. Cognitive behavior therapy, we go on to find out the patient's cognitions. What are the faulty cognitions? What are the fears? If there's history of abuse, we go on to reconstruct the whole past event and then come back to therapy. So this is CBT started right from the beginning of the therapy, right from day 1, and it has to be continued till the end. Sensate focus, when everything is done, the patient is ready, we advise, or throughout the therapy, we advise that the husband and wife do not have any sexual contact, or other things can be allowed. That is sensate focus, and then couple therapy is advised. Thank you.
Thank you, madam. Sir, we have not finished yet. We must be having some points of discussion.
I want the first question to be answered very shortly, so that I can put in my second question. Whether vaginismus is due to something entering the female part, or whether it is entry of the male organ, that is which is it both, or is it one of them, or it is everything?
It is anything, penetration of anything. Even
Penetration.
when we do gynecological examination or we do PV, patient has pain.
That is the general. You talked about biothiometry, the stimulation of clitoris. Now the same thing can be done by the husband.
Yes, we usually advise the husband only to do that. What under therapy everyone is doing, usually the therapists they do it, but up till now all my patients have asked the husband to do that.
Excuse me, 8 minutes. Can forced marriage or dislike for the partner can also be one of the reasons for that?
Yes, but that usually it is psychological. If she doesn't like the husband or she has some conflicts, definitely that pain is going to be there. So you have to go and solve the conflicts.
I request Dr. Bhagishri madam to. You have question?
Actually, we are discussing the topic of infertility. You have told us about vaginismus related to infertility. But we have seen many patients who are very anxious to conceive. Means, will you put some light how psychiatry will help on this? They don't have any diseases or related to gynae, but they are very anxious to conceive.
Yes, anxiety is there. So we have to address that anxiety, whatever is causing that anxiety. If it's an anxiety disorder, we have to give some slight anti-anxiety medication. Some medications are totally safe in pregnancy, we can give them safely. So we can give some medicines along. If it's mild anxiety, we can counsel them depending on whatever the issue is. What is the factor that is, maybe she wants a pregnancy fast, or maybe there's a lot of pressure from the family. So we can address all those issues, how to handle those thoughts. If we are able to teach that, her anxiety should go off. Thank you.
I request Dr. Bhagishri madam to kindly felicitate Dr. Sanakhi. Next topic of discussion, OHSS free clinic by Dr. Reshma Khan madam. She, after doing her MD in OBGYN, has done her fellowship training in infertility and IVF at National University, Singapore. She is an international clinician that I would say. She has also seen Arabs, Asians, Caucasians, and all the patients. Madam is working in our city since last 10 to 15 years, and she is director of International Hospital. I call upon Madam to kindly take the mic for her talk.
Thank you, doctor, for your kind introduction. I think I'll be audible without my. And with lunchtime nearing, everybody's sugar level going down, I'll try to be fast. I promise this, okay? What is OHSS? This is ovarian hyperstimulation syndrome. It is a broad spectrum of clinical manifestations from mild illness needing only observation to severe disease requiring ICU hospitalization. Hence, clinicians who prescribe ovulation-inducing drugs must know to recognize and manage ovarian hyperstimulation. Actually, when I was told by the organizing committee to give a presentation in infertility, my first question was, are the audience gynecs or non-gynecs? You told me non-gynecs. So the task became a little difficult to choose a topic of infertility which could not only be of interest but of use to the non-gynecs. I was thinking what to get. Then a patient with abdominal pain walked in my clinic and I got my answer. This patient, she presented with abdominal pain. She was prescribed ovulation-inducing drug by a general practitioner. And the dose was right. But she took medications, and after on day 10 or day 12, she started having severe pain. She went back there, she was given some buscopan routine treatment and sent back. Then not relief, she came to me. When I put the ultrasound probe, I saw 2 enlarged ovaries with little minimal fluid. It was ovarian hyperstimulation syndrome. Then I got my answer. So I thought if there are non-gynecs, just let me speak about this. That doctor was not right. He gave the right drug, but the dose was not right. So we will see how to choose what in next of this. No. OHSS is the most serious complication of ovulation induction. In the incidence is only 3 to 6%. 3 to 6% patients end up with moderate OHSS. Only patients end up with severe OHSS. And mortality has also been reported with ovulation-inducing drugs. Up till now, 500 deaths have been reported in the literature. And mortality is 3 per 100,000 cycle, which seems to be less. But when you operate a high-risk patient, you operate a cancer patient, the family and the patient knows but the patients of infertility coming to you are young, they are healthy, and they are aspiring for pregnancy, and you give death is not at all acceptable. So we need to be very careful. Now, what should be the goals of ovulation induction? The goal should be you have to maximize treatment benefit to the patient while minimizing the complications and risks. Our aim should be of single pregnancy. Our aim should be that we give medications, ovarian hyperstimulation and we cancel the cycle. No. Earlier, it was very much common. We would read in the newspapers, there have been 5 births. One lady has given to 7 births. No, again, this is a complication of ovulation induction that is not acceptable. And of course, the most serious complication of ovulation induction is ovarian hyperstimulation syndrome. Pathogenesis. What is the pathogenesis? As usually happens in medicine, still unclear. But the most proposed theory is HCG. HCG is found to be the culprit. What does HCG do? We give, once the eggs are ready, we give injections for the rupture. HCG injection. What does it do? It doesn't increase the vascular permeability directly, but it releases some vasoactive amounts, which is vascular endothelial growth factor. What does this cause? It causes shift of fluid from intravascular compartment to the third space. We know what happens when the intravenous fluid is shifted, extra transudate occurs. So you get ascites, you get pleural infusion, you may get pericardial effusion, and the fluid goes out. What happens? There is intravascular depletion, and then the subsequent sequelae. Intravascular depletion, we know it causes hemoconcentration, and once hemoconcentration occurs, patient will go into venous thromboembolisms. Again, this is to show the action of this VGEF, that it increases capillary permeability plus it induces endothelial cell proliferation. Now, there are two forms of clinical forms of ovarian hyperstimulation. It can occur either early, either late. So, when does this early? What happens when we give an exogenous HCG injection for rupture? This occurs, and this occurs within 3 to 7 days of giving HCG. And the late onset is once the patient gets pregnant. Why this occurs? Because the blastocyst starts secreting HCG. Now, early onset, it is predicted. This can be predicted by growing follicles. As told by Dr. Farah, PCO patients have many follicles. You give HCG, everybody will start releasing hormones, and patient goes into ovarian hyperstimulation. And again, twins patient, number of gestation sac is more chorionic pillar, more secretion of HCG. Early onset OHSS, patients end up with high preclinical miscarriages. And late onset OHSS, what happens? Patient is pregnant. You can't do anything. You have to wait for the HCG to subside. So this is more severe. Now, what are the forms? Mild forms, moderate and severe. In mild, patient may just present with abdominal distension, only nausea, and on ultrasound we see enlarged. In moderate, all the symptoms of mild but ascites. And in severe form, what happens? Patient presents with severe nausea and vomiting, may present with oliguria, rapid weight gain, syncopal attacks, or directly with venous thrombosis. Again, in mild forms, there is no any lab alterations. So, in moderate forms, you see that hematocrit goes slightly higher. And in severe forms, the hematocrit is more than 55%. You may have raised LFT, raised KFT, all those things. And about treatment, mild is just we reassure the patient. Moderate is requires clinical monitoring. Severe is hospitalization and ICU care. Now, what are the complications of ovarian hyperstimulation syndrome? It causes a huge psychological burden on the patient. There is high cycle cancellation rate. Just imagine ourselves taking those thousands of rupees gonadotropins and the doctor tells, "Nahi, abhi tumko ovarian hyperstimulation hoga, we will not give the further treatment." Then, if the patient gets pregnant also, there is high risk of miscarriage. Now, severe cases may get even worse. Patient may end up with acute renal failures, arrhythmias, thromboembolisms, pericardial effusion, massive hydrothorax, sepsis, and ARDS. The truth is, ovarian hyperstimulation syndrome must be prevented rather than treated. Now, in management, we will see 4 primary preventions. What is to be done? Identify patients at risk. That is patient of polycystic ovaries. They go into OHSS very fast, so you give less the dose. As the case I mentioned, that doctor, she gave the right dose, but that patient was young, she was thin-built, she gave the right drug, but not the right dose. The dose should be half, she gave the normal dose, so patient went into ovarian hyperstimulation. So when we find that this patient may go into risk, we have to lessen the dose. Or when you feel that the situation is out of control, better cancel the cycle. Nowadays we have this, we are coming up with GnRH agonist instead of HCG. Now secondary prevention is we give intravenous steroids. Dopamine agonist is giving us promising results, and sometimes we give antagonist in the luteal phase. Now, who is who before ovulation induction? As I told, again, if young patients, we less the dose. Low BMI, give less the dose. Polycystic ovaries goes easily into ovarian hyperstimulation syndrome. So, again, you have to be very careful. Any patient coming to you, just take the history, whether she had ovarian hyperstimulation in her previous cycle. Again, you be cautious and minimize the dose. so that patient doesn't end up with this complication. And now we have two very good biomarkers. With the help of that, ovarian hyperstimulation syndrome rates have decreased a lot. What are those biomarkers? AMH and antral follicle count. In antral follicle count, we just call the patient on day 2 of the periods and we count the number of follicles in each ovary. So what is the cutoff? More than 16 antral follicle counts, we need to, it predicts that this patient is going to ovarian hyperstimulation syndrome with sensitivity of 100%. So we are very cautious and we cut the dose. And again, when we routinely do the AMH, any AMH more than 3.36, then we keep our fingers crossed that this patient can go into ovarian hyperstimulation anytime and we decrease the dose. This is just to show that if it is PCO and all, we start with mild stimulation. And this is again, situation out of control, counsel the patient, cancel the cycle. So, but again, cancelling the cycle will cause frustration in the patient, waste of time and money both. Again, this is, I think this will be of more interest to the gynecologist rather than all the other people here. We give GnRH agonist for instead of HCG, which is decreasing our OHSs a lot. Again, these are the same slides, I'll skip this. And nowadays, whenever we are doing egg collections and all, we suspect ovarian hyperstimulation, we give prophylactically IV albumin. This is to increase the oncotic pressure and reverse the leakage. How is this albumin given? 25% albumin. At the time of oocyte retrieval has been suggested as a means to reduce OHSs markedly, or if the patient has previous episode of OHSs, we give albumin. And cabergoline, this is a very simple and promising drug nowadays to prevent OHSs. When should we start? First, let's see how does cabergoline act. Again, it acts on the VGEF by decreasing the production, so there is no, it reverses the capillary leakage. 0.5 milligram per day for 8 days. When should we give? On the day of SCG. Now, how should we treat mild OHSs? This can be treated at our OPD level, conservative management, just reassurance of the couple, give plenty of fluids, counsel the patient that if more than 2 kg, report us. If she gains more than 2 kg weight, report immediately. And to minimize the physical activity, because the ovaries get enlarged, it can get torsion anytime. So what are the indications for hospitalization for OHSS patient? It is intolerable nausea and vomiting, hypotension, respiratory difficulty, signs of pleural effusion, ascites, hematocrit more than 48%. So any patient, if I suspect that she may go into OHSS, I do a baseline hematocrit and keep in that OPD level so that when we come for monitoring, we can compare it. So any high potassium, serum potassium, creatinine, in all these cases needs to be hospitalized. What we do is just to maintain intravascular volume and electrolyte balances, and we give enoxaparin to the patient, low dose prophylactic dose 1 milligram per kg, just to see that she doesn't go into venous thromboembolism. Of course, if renal failure, we manage it accordingly. Critical OHSs, what we do, again, it is a multidisciplinary approach, strict fluid and electrolyte management with crystalloids, IV albumin. Again, we give thromboprophylaxis as mentioned. If the patient has too much of abdominal distension, ascites, abdominal paracentesis is done, pleurocentesis is done, which relieves not only the symptoms, but promotes, again, it also promotes diuresis and clinical resolution. To end my presentation, just I'll give 2-3 key messages. Improving patients' welfare starts right from identifying the patients who can go into ovarian hyperstimulation syndrome, and it continues by individualization of the stimulation protocol. Not that one size fits all. This is the drug, give for 5 days, this is the dose. No, you have to tailor your dose according to the patient. If you feel that a patient has a hyperstimulated, don't give HCG, go for a GnRH agonist trigger, it will eliminate OHSs. Secondary prevention can be done by cabergoline, as already mentioned. And the last is, again, OHS has, ovarian hyperstimulation syndrome has to be prevented rather than treated. Thank you. Any questions? Last questions should be ready by now. So I choose the right topic again.
It is a nightmare for patient, but it is also nightmare for the infertility specialist who is treating.
Yeah,
Because I have seen many people planning it, fluid infusions, SIT,
yeah,
DIC even. So it is very difficult situation to manage.
yeah. But I think nowadays you should be getting less because we are giving GnRH agonist instead of HCG.
Yeah. Initially I used to get more patients.
Yeah, before 4 or 5 years that was the thing. But since 4 or 5 years we shifted giving it product this can go into OHSs instead of HCG injection for rupture. We are giving GnRH agonist, and alhamdulillah very less patients are like that.
I've seen one patient even with the GnRH agonist, only one in these
Yeah.
years, she still added
Maybe her AMH was very high and all those things.
You can refer the physician.
Refer the patient doctor. If you smell OHSs, we have an expert sitting here, you can refer them.
5 seconds.
with agonist that she'll have to freeze or like if you
Yeah.
she'll not conceive it.
So nowadays the best what we are doing is पहले कैसा है IVF के patients काफी जाते थे, we give this, you feel that this patient can go in OHSs, take all the eggs, make the embryos, keep, let that OHSs subside, in next cycle you put it, so that HCG level will get normalized. That is the reason less patients you are getting.
It is a protocol of Elite Academy that if a proud relative is present, so that relative will felicitate the speaker. So we have a proud relative, Dr. Aska Hadri Madam. She is the nephew of Madam. So I request Madam to kindly felicitate. नहीं हमेशा से Thank you, ma'am. So, we are being getting stimulated by the aroma of food. But before that, it will just take a few minutes for our senior to evaluate the event that has gone on from morning till up till now. So I call upon Dr. Ehrar sir to kindly give the keynote, and then let's end up the session with the feast of lunch. The chair will be.
Dear academics from Badnapur who have organized this, the faculty who has presented this very beautiful talk, and well, audiences. I come from a period when boys were better than girls. You felt boys were better than girls. A little bit of that still remains in my mind. Not exactly the alpha male kind of thing, but we boys are better than you. Today sitting here, I felt a strong inferiority complex for the first time in my life. When I found that there are too many girls who are better than me. So you see, these are the experiences of the life. And one thing that I have found that whatever may be your field, you should never shirk from trying to learn something from the other field. Never share from it. You always have something for you. For example, now people might be thinking that whatever I have asked, it was just for travel. No, it wasn't for travel. अरे ससुरा हूँ यार मैं, बहू है मेरी, बहू थी, बहू है, अब लड़के हैं, शादी होगी, तो ये सब प्रॉब्लम जो आपके गहना के हैं, at some point my children will ask me, और मैं ये तो नहीं बोल सकता कि भाई मैं यार I don't know anything. Of course they have already started suspecting that I am really a doctor or not, because an ophthalmologist is so out of the field that he is not considered actually a routine doctor. Anyway, the talks that were presented by Sayyida Afroz, Dr. Bhagyeshri, Dr. Ishraq, Dr. Faradiva, and Dr. Sana Khadri and Dr. Reshma Khan, they were so clearly elucidated that even an ophthalmologist could understand what they were speaking. And this is what actually I want to convey to my colleagues. I want my colleagues to say that whenever you speak, try to use as less jargon as you can when you are conveying the idea to the people, to the general masses. When I am sitting there, for example, when the last talk started, OHSS, Reshma Madam started that. Really, I didn't know what it meant at all. So I asked Umar Khadri, yaar ye OHSS kya hai? He explained to me, I got the idea. And then I followed the whole trail. The thing is that our aim should be whatever I speak, the one who is listening, he should get it. And well, I should ask my male colleagues especially to give a big hand to the girls of today, who have really proved this boy that no more the boys are better than the girls. With that, I end this little keynote address, and thank you very much.
I would add that it is duly proven that the gender equality is maintained, but I still request Dr. Faisal sir to establish a center for male happiness also.
It depends on the female happiness.
Yes, because it depends on.
If the female is happy, male ultimately becomes happy.
Yes, that's what I wanted to say. मैं भी वही बोलने वाला था कि when the woman is happy, the whole family is happy. Yes. So that's the thing. और second ये है कि boys are always not better than girls because हमको घर जाना है और खाना खाना है.
With this, I really thank Dr. Erar sir. He is a constant, delegate of elite CMEs. In all the 3 CMEs, he has motivated us, and he is always being a constant support. So I request Dr. Shafi sir, Director of Elite Academy, to kindly felicitate Dr. Erar sir. I also call upon Dr. Jawad sir to please join us in felicitating Dr. Erar sir.
So before we break for the lunch, I'm very thankful for all of you for coming and attending this CME. Actually, the last CME we had in July 2nd on obesity, that time also Reshma has presented very well. So I consulted her that we are planning to have a CME on infertility, but I was not thinking that only female delegates will come for that CME. So that has become a little bit disappointing for us that we could not get much number of delegates for this CME. So ma'am has suggested all the topics which were planned for this CME. The agenda is from her, and she herself told that she will speak on OHSS cleaning. That also we were also not knowing what is OHSS. Later on we came to know